So dear students, will be discussing about amblyopia management, both traditional and the newer perspective, because whenever we start something new, we should know about the old one, or which is continuing for over years and years. So to understand what are the merits of it and what are the lacunas available with recent treatment protocol, so that we can move further and learn many things more. So as all of us know that amblyopia, especially it's unilateral, or less commonly it is a bilateral reduction in best corrected visual acuity, where it is not contributing directly to any effect or structural abnormality of the eye or in the posterior visual pathway. So this is more of functional in nature. What all other definitions that comes into this place of amblyopia is there are reduced visual acuity, which is not improved with refractive error correction or not attributed to any other structural enmity. The defect of vision owing to the absence of adequate symmetrical stimuli to the both eyes, so that binocular reflexes cannot be developed. Now coming to the last definition. So it is, though it is not very common, but it is talking about the binocular stimulus when it gets affected. So likely to patient likely to get abnormal visual development and response to the visual cortex. Now coming to the next slide, if you see the prevalence is very common. Very common is in total population. If you see pediatric and adult population, 2 to 4%. It is reported in Northern America, but I was just going through some Indian literature which says around some 3 to 5% of population that got amblyopia. And more to that, most of this patient that who undergoes or amblyopia therapy, they are still left with some amblyopia component. And there are many people who come across at very later stage of life, and those are untreated, usually at the age of 16 or 18 when they goes for some medical examination or for some job interview, or when they go for higher studies, they come to know that there is an issue in their visual system, and they come to know. So as I was discussing, the most commonest form you can get is the unilateral in nature, and then nearly all amblyopic visual loss is preventable, or is that you know that there are certain plasticity period concept. So we'll talk about the neuroscience, how the amblyopia occurs, and we'll discuss how we can manage this condition. Now, children with amblyopia or at risk should be identified at the young age, is because you can manage them easily and efficiently. You can develop their binocular vision functions in a better way when you detect them early and manage them in an efficient way. So let us see how people feel, whether the most commonest cause of amblyopia is congenital cataract, anisometropia, high isometropia, or strabismus in onset. So as I can see, a 64%, more than 64% is voting for anisometropia, which is the commonest in nature. Again, as we know that amblyopia is most commonly unilateral and there are bilateral processes. So what do you think that the problem in the visual system is? Whether it's in the level of eye, optic nerve, lateral geniculate body, or visual cortex, or it could be anything or many of these. Okay, can you say that 89% felt it is in the visual cortex? Very good to know. So that means we are in a process to understand, yes, amblyopia is something, is more of the last definition we discussed about is the binocular stimulus that which is probably affected during this process of time. So if you see in the ocular process, first order, second order, and third order neurons, which are monocular in nature. So we need to remember there are two kinds of pathways that we have in the process of visual system. One is monocular neurons, and next followed by is the binocular neurons. So monocular neurons got a plasticity period which is said to be till or up to 10 years of age most of the time. Sometimes it can be extended till 12 or 13 years of age, but maximally it gets matured by the age of 10 years or so. That's why if you do patching therapy before that period of time, you do get improvement. But suppose that once the plasticity goes off for this monocular neurons, you do not get sustainable results in amblyopia therapy by means of patching. But look at the lateral geniculate body, which is the fourth order neurons. Again, it starts the first set of binocular neurons. So actually, the first problem starts occurring in the set of binocular neurons, which is at lateral geniculate body and the thalamus, and then you have visual cortex, Brodmann area 17, right? Fifth order neuron and extrastriate cortex. So you rightly pointed out that it is actually a binocular issue and more on visual cortex, but not to forget about the lateral geniculate body as well in this process. Now, what happens a little bit into neuroscience? Let us understand what happens in this process, why there is amblyopia occurs. So when there is a stimulus deprivation or there is improper image formation in one of the visual cortex, then the cells becomes pale and shrunken. So if you see normally the visual cells, if it is pale and shrunken, then the capacity of visual resolution or recognition becomes less and less. So that's why it gets affected. Now, it occurs only when there is an early deprivation in a proper visual stimulus. Then if you open the eye, or if you open to that component of which was having issues in getting proper response, so even though if you open that eye, it did not get recovered. So you need to understand that if there is a improper visual stimulus, the cells are becoming pale and shrunken. But if you remove that stimulus, because these are binocular neurons, even though if you remove that thing, the obstacles, but still the visual recovery do not happen, or the cells recovery do not happen. So if then you start closing the good eye at the critical period of time of the monocular neurons, there will be some recovery and there will be no diffuse atrophy if you can start as early as possible. So one pathway from the one eye took over the territory of the closed eye. Here the concept of the visual dominancy comes into place. So whenever you get this kind of one eye having, or especially in the unilateral amblyopes, when you have improper stimulus in one eye, then the visual territory of that eye is actually overtaken by the other eye. So that's the process called visual dominancy, or there is an interocular separation process takes place, and the better part of the visual cortex takes over the bad eye. Now, if you see the cell mapping, what it happens in the visual cortex area. So in Brodmann area 17, especially more focused in the 4C. So marked shrinkage in the input stripes, ocular dominance column. So if you see the ocular dominance column, then the other side there will be marked shrinkage in the input. The expansion of the non-deprived eye. So again, when there is a better eye, there will be expansion of these stripes. That means again the dominancy is coming into place. And quality related to the depth of amblyopia exactly depends upon how much area of this visual expansion that will happen in the visual cortex. So larger the expansion, more denser the amblyopia is going to be. So by this we understood that amblyopia is largely a process of binocular in onset, and the management till now what we do is at this point of time it involves that eliminating of any possible obstruction in the quality of vision. It could be a refractive correction, it could be stimulus deprivation, any causes, so that you need to correct and give a full refractive correction. And then you have to force that eye, which is poorer in nature, to integrate with the better eye and form a better visual system. But we need to always remember this small amount of neuroscience, that it is a binocular in nature, and you are giving a lot of interocular dominancy that is getting created, and you are also creating in the marked dominance of the visual inputs that is happening in one side of the visual cortex, which is getting a better image. So once we keep this in mind, then our management plan becomes smoother and better. So again, to recap on the neuroscience, if it is happening before the age of 10 or so, then we know that plasticity of the monocular neuron is still active, and then we can manage it a better way if we can start. If it is later than that, then it is the only binocular neurons which are active. And to remember, these binocular neurons are active throughout our life. So there is no plasticity, so-called plasticity of 8 to 10 years for these neurons, which is a good the boon for us to manage it. So coming to the next question, what is the commonest or the gold standard for our amblyopia management? Okay, so there is 52% of you feel that occlusion therapy is gold standard. Some of you, or 28%, feel combination of all, and then followed by you feel that dichoptic therapy is a gold standard. Now to the maximum, because maximum people usually never goes wrong. So it's occlusion therapy which is gold standard at this point of time. Whatever it is a like age-old proven methodology or management protocol that is there since years and years. Now we need to understand what happens with this management protocol, what happens in occlusion therapy. So if you remember again the first concept, or the plasticity of the monocular neurons, right? So it helps you just by covering the non-deprived eye. You are forcing the other eye to learn better and have a better visual experience. And the brain, or the area which was getting shrunken, it is slowly starts using, and then it becomes better and better. So you can have very overview. I need to take you through because I'll be discussing something else in detail. So you can have a constant or occasional occlusion, or you can have a total occlusion or partial occlusion based on the severity of amblyopia, based on the progress, and about when you started this therapy, how early you started this program. Sorry. Now, mechanism in strabismic melopia, what it does, it patch over the fixating eye so that it forces the deviating eye to come into the fixation and then start having the visual function. In anisometric amblyopia, when you patch, it eliminates the inhibitory influence that was coming from the dominant eye in the visual cortex and start functioning. So two different mechanism into different kind of condition. And in cases of isometropic and bilateral amblyopes, so there is no definite rule. So there is no gold standard as such. People does alternate patching, but there is no consensus amongst the pediatric ophthalmologist or optometrist group at this point of time. There is no concrete literature that supports that only alternate patching is the gold standard for this isometropic amblyopes. So recommended schedule, if you bath to 1A, then patch the good eye 2 days and then patch the poor eye 1 day, so that there is no reverse amblyopia occurring. If it is 1 to 3 years, then 3:1, 3 to 4, 4:1, and 4 to above, it is 6:1. So this is a standard recommended schedule for treatment of amblyopia by help of occlusion therapy. Now you can have different mode of occlusion. You can have patches. You can have nail polish to just paint the spectacle lens, or you can custom made patches attached to the spectacle frame. So that is depend on the availability, economic values of the particular patients related. In penalization, so When the compliance with the patchings is very poor, or patient is not going to adhere it, or you know that patient is having some other conditions where the spectacle option is not appropriate, then you start giving penalization. Penalization you can do by form of any cycloplegic. You can have atropine or homatropine or cyclopentolate to start with, but most commonly practiced one is the atropine 1%. Now, how you do that is you can have a near penalization, distance penalization, and total penalization. This is overview. Now, when you used to give a near penalization, what you do is in the normal eye, you give full distance correction along with the 1% of atropine. So what it does, it will blur the near vision, and in the better eye, you give an overcorrection of 2 to 3 diopters so that I have a very good near vision. For distance, what you need to do is in the atropinized eye or in the better eye, overcorrect but plus 3 diopters. So once you put atropine, then it relaxes a complete accommodation. And the moment you put plus 3 on that eye, near vision becomes better in that eye. But distance vision, due to this excessive pseudo myopia of plus 3 diopter, they do not see proper for distance. And you give proper correction for the other eye or the amblyopic eye. And if you wish to give both of distance and near penalization, so in the better eye, again, you do atropine or cyclopentolate, give a overcorrection of -4 to -5, so that they neither see for distance and not for near. So -4 and -5 takes care, or around that power takes care that patient should not see distance clearly, and the atropine effect makes sure that near vision is not clear. And the better eye, you give a proper correction. So being these two standards, which is most commonly the patching and then the occlusion followed by the penalization, then why do you need this approach for management in a new form? So what are the major limitations of present gold standard or occlusion therapy? Again, we need to understand this, why there is a need for change, why the age-old tested method that is going for years and years, we wish to tweak it, I wish to make it better. So as you can see that 49% you fail, that recurrence of amblyopia is most common, then followed by, you can see 36%, 42% of poor compliance, then 36% of poor binocular vision, and 29% of non-effective in older children or adults, and then residual amblyopia. Excellent. So let us go through one by one and see how many of you are correct. So exactly first or the foremost things comes as the residual amblyopia. So if you see this ATS2A, ATS is amblyopia treatment study, stands for the largest treatment protocol which was carried out, as I talked about, by pediatric eye disease investigator group. So if you see that whenever you treat any amblyopia with occlusion therapy, so more than 80% will have residual amblyopia more than 2 lines, so 2 logmar lines. So maximum what you are attaining is probably 12 visual acuity, 9 visual acuity when you are talking about logmar. So it is 0.02 logmar visual acuity, and which is quite significant. That 80% will left with this residual amblyopia. So that's the saturation level. When you have a monocular process to treat, when you treat with patching or occlusion therapy, then it has a success rate or giving 100% vision or having 20/20 vision or 0 logmar is only 15% cases, right? And this is not what we are talking or doing some assumption. It is the largest group that talked about. And even though if you do full patching, 3 to 7 years of age, severe amblyopia group, like 6 hours a day, they did it, but still the same component. And there are studies who did complete occlusion, 12 hours a day, but still there was no better results than this. Right, coming to the next, as you rightly pointed, the compliance is poor. So what happens to the compliance of this patient as the childs grow up? Then the compliance keep on decreasing. Now, when a child becomes more than 5 years of age, the compliance goes down less than 50%. So if you adhere to the protocol of saying that, okay, at a 5 years of age, you need to do around 4 hours of patching a day, yes, they will do end up with only 2 hours or so. So that means there is a 50% drop in their adherence protocol. And the adherence to any kind of treatment, whether you do it for amblyopia or any disease condition or any ocular condition, the compliance to the management protocol is very crucial. If it is not followed, then you will have issues or end up with some optimal acuity gain or improvement in the thing. So coming to the next one, the time it takes, it's months or years. Some people, probably you saw that child is doing patching therapy for 3 years, 4 years of time. There are every 6 months probably half a line improvement or 1 line improvement in logMAR visual acuity chart. If it is nils, then you may not see an improvement in early treatment phase, because from 660 to 648, then you have a large gap over there. So the first test reported visual acuity improvement, which was there 4.8 lines in 4 months period of time with a protocol of 6 hours a day patching. That was published in 2003. But usually it takes months and months. That is based on the practical experience that all of us has who are doing this amblyopia management for a couple of years now. Coming to the next one, the adult amblyops. Again, you rightly pointed out, when it is especially older age group of children, it do not help in improving the visual acuity. And there was a study of 7 to 17 years, which they failed that there was responder itself which was very poor, and in that responders, most patients, including the response, are left with residual amblyopia and acuity deficit. So it do not work. It has that component of saturation, visual saturation, and the maturation of plasticity of monocular neurons. So if you try to give patching therapy, it is not going to help anymore with this group of patients. And even though there is a few lines of improvement in this older age group or children or adults, the moment you stop the therapy, all likely the vision is going to go down by again to the baseline level. The next common one is the recurrence, which you pointed out is the highest one. Is again, it is very high. 24% of successfully treated amblyopic patients. So those who treated completely, those 15% of population whom you treated by 100%, even those 24% will have recurrence, and usually 8 to 10% will have more than 1 line drop in their visual acuity. So you need a maintenance patching again for a couple of months or years to keep the amblyopia in check, and which is a tedious process. Now we talked about so many things, but we never looked at the binocular vision parameters. So we have 2 eyes. So there are certain aspects in the binocular vision. That's why God gifted us with 2 eyes. We always focus in amblyopia management as a monocular concept. We never looked at what happens to their fusion and stereopsis, what happens to their fine motor skills like hand-to-eye coordination and the saccade pursuit. So these are the components which are again looked at, but it was actually a major deficits in monocular approach of amblyopia management. So these all components, all the issues led to thinking about something beyond monocular therapy, or something to have little bit of innovative, so that you can effectively manage those or outcome those concept or the therapeutic. Does it leads to the concept of dichoptic therapy? Let us hear it how it.
Dichoptic therapy, a contrast-adjusted stimulus, is presented to each eye, with the better eye getting the stimulus with reduced contrast. It promotes development of binocular vision by reducing inhibitory interactions and suppression within the ocular dominance column.
So if you see what was happening as I was talking about, because of the dominancy of the dominant eye, the deprived eye or having amblyopic eye, the visual system or the visual cortex was not accepting that image. Now, if by any mean, if you can alter the contrast function of the dominant eye, so virtually you are not playing with any acuity or occluding the vision of the dominant eye, but you are trying to play with the contrast of the dominant eye so that the interocular dominance goes down, which is very crucial, and that leads to a binocular perception. Brain start using both eyes image, and if you remember the concept or the neurophysiology of development of amblyopia, it was binocular nature. Whenever there is a dominancy, then it was leading to amblyopia. Hence, if you can follow a path which can reverse that process by a mean of altering the contrast of the dominant eye, which will help you to improve the amblyopia. And there are quite few literature. I just name few of them, key of them. So Professor Hayes started long back on this concept in 2010, and then started in 2006 around or so, and published in 2010. And then there are numeric literatures coming every day or every month. If you see a new publication which is talking about dichoptic therapies, and this is why the people started talking about dichoptic therapy, as it plays with contrast and gives you better improvement. So by now, when we talked about the neuroscience, when we talked about the process of dichoptic therapy, so even before we go into the concept of dichoptic therapy, let us understand what all the probable advantage that dichoptic therapy can have with this amblyopia management protocol. Okay, good to go. So let us show you the results. Perfect. So you can see many improve binocular vision, may improve binocular vision parameters because you are looking at dichoptic approach or binocular approach, followed by 48% failed that it will have a faster effect, 45% failed could be effective in adults, and then 43% better compliance, and then very few of you failed that there will be no recurrence of this program. So we'll talk one by one what things happens in dichoptic therapy. So to started this process of altering contrast, it was there. I think there are a trial of giving a poorer contrast, but with this help of Bangalter filter, it was not only reducing the contrast of the better eye, it was also dropping their form sense in a significant way. So it forms as part of penalization, but has component of binocular in nature, and it is a dichoptic in nature because you are altering the contrast in this by the grades or the gratings that you have in the Bangalter filters. So it again helps in the same concept what I showed in the video, that it try to decrease the interocular dominancy and helps in binocular interaction. In this picture, you can see that right eye child is having a Bangalter filters. So virtually it is reducing the contrast of that eye and promoting a binocular concept of visual acuity development or visual functions development. Now there are many more things that we can do in this concept. So the commonest thing that we can perform is something called monocular fixation in a binocular field. In this process, it stresses that when it is monocular means you are giving something specific target to particular eye, target to the dominant eye and then non-dominant eye at same point of time, but keeping the background visible for both. So area of interest or the viewing area is common for both, but you have a specific task assigned to specific eye, and that's the component of this MFVF. To induce MFVF, the commonly method that you use is anaglaps. You can have red and green or red blue, red cyan anaglaps, or you can have Polaroids. You can have active 3D glasses. So all these things possible to induce this MLPF concept. So what exactly it does, so if you see that without glass, this card is showing that one eye is white background and other is red background. The moment you put the filter on, when the red filter is on and cover the green one, so you don't see which is there on the white background. It is neutralizing. But the other hand, the red filters with the red background can see a black things which are there. Exactly opposite, when you are covering the right eye, or in this case the red filter, you can see the other card, and when both the eyes open, you can see both of them. So that means the similar target is projected in both the eyes but has different color saturation based on the Avana gloves you are using, and the patient activity is happening which is in binocular in nature. Now, only demerits with this concept that you are not able to play with the contrast, though it is monocular fixation in binocular field, but the major limitation is happening, you are not able to play with the contrast, which is crucial as we discussed, that you need to change the contrast level of the dominant eye. And how you can give a furthermore for kids and anybody, you can have a felt tip pen or a HB pencil or a color pencil, and assign the task patient wearing this anaglove goggles or red green, red blue, or red cyan goggles, and give the specific pen or color pencil so that they can start practicing. This is a good tool to improve the visual acuity. If you can alter the contrast over a period of time, if you have a multiple density or the thickness of the tip of different shies, then it makes more efficient with this management protocol. So these are very good or handy home therapy tools for amblyopia management. You can have a heart chart or on a background like this, and give the specific target or patient to read about. Just induce the filter on top of this chart, put the anaglove goggles on based on the acuity, and then the amount of amblyopia. Then you keep on exercising or ask them to read with these things. Very commonly, what you can do is even the television screen, you can cover it with this particular filter, red or green, based on the amblyopic eye, and then they start using that eye more oftenly. Or in case of right eye, so you can put that filter accordingly, and the left eye the other way around. There are many games which are available and still available based on Professor Hayes' concept of Tetris games. So you have stereo blocks, lazy eye blocks and Duovision games in Android app, which again you can give it to the patient. Now, added advantage to this particular activity is you can play with the contrast. From the other analog model to this model, when you're coming to the app based, you can alter the saturation level, and that's make it more effective. But the demerits major lies in the adherence or the compliance. As you know, any protocol or any management protocol, the adherence is to be complete to get a better improvement. So in this case, because it is monotonous in nature, the child's it opts out. Or in adults, they do not like to play this kind of activities, Tetris activities, and thus it results in poor outcome of the program. You can have lazy eye snake games from Android games. You can have Apple games of lazy eye bubble shooter. You can have lazy eye breaker. You can have jump and fly. And more recently, you can have more sophisticated games like Digrash, which is there on Android. So you can play these activities. Now, all this, you play with contrast, you try to engage the patient more and more so that you can yield in better visual acuity. Now, given this, all of the concept or all of the these tools which are available on App Store or Play Store, the Digrash has much superior result because it is not because of iPad game, it is because of the activity or compliance to the protocol, because of the incentivizing the patient of giving bonuses or a different target makes it more effective. Though the concept is purely dichoptic, where you play with the contrast of the dominant eye, keep on reducing, try to balance with the amblyopic eye, and start playing these games. Now, more recently, there are different concept of dichoptic movie watching that has also come, which is name of curesign. And what it actually does, it virtually convert any kind of video into dichoptic movie watching. So there are plugins which are available. You need to attach to the viewing system, and you can use red and blue filters to watch this movie. So they are converting cartoons or any kind of television movies into dichoptic movies. So I'll be taking the questions. I can see there are chat box, there are questions coming. I'll definitely take on them. Let me just complete a couple of slides. Sorry for the inconvenience, but that will keep my flow intact. Now, moving forward with this concept, more and more things are coming with this going on. Now, as you know, when we worked upon this concept of improving the acuity, then we need something to hold that acuity, whatever you are gaining. So we felt that fusion and stereopsis can be one of the finest glue that can hold the amount of improvement that you get in amblyopia management. Thus, when you improve somebody's binocular function, rather improving just monocular, that becomes more effective. So we expect when there is a fusion stereopsis present, less likely the brain is going to again suppress the non-dominant eye. Very unlikely. So why suppression happens? Because there is an interocular dominancy, there is probably no better fusion or stereopsis. But with the development of fusion and stereopsis, that goes off. So the recurrence chance with dichoptic or binocular approach is very, very less. So over a period of 3.5 years, we have not seen a patient that recurred into a amblyopic condition post completion of therapy or post completion of management. So Broxting is one of the great tool for anti-separation and fusion development. So it works on physiological diplopia. So you are training the brain on like perceiving the concept of physiological diplopia. So it tries to remove the separation strong way and also improves in fusion. And you can train on divergences for this patient. What are the other methods that are available to improve this binocular function in amblyop? So when you are giving app-based therapy of monocular fixation in binocular field, then these are the therapies you need to incorporate into it to become a successful therapeutic program for any particular amblyopic patient. So we got aperture ruler, where you can again train on fusion, convergence and divergence. Then you have vectograms, which is again very good tool for fusional divergences along in stereopsis development. So again, if you see that Polaroid is being used to create the dichoptic environment. Now the major limitation in all three activities, though it has very good success rate, is you are not able to play the contrast of this individual game. So if you wish to decrease the contrast of a particular eye, which is limited because these are fixed subset of parameters, so you can't alter the physical or analog model things. Thus, we believe over a period of time, what happens, there are computerized orthoptics that has come. Many orthoptics program like HTS has, you can see QRC has, Neuropy, TRI, which all has this fusional component or fusional apart from those monocular fixation in binocular field. So there are computerized controlled fusional like activities where you can improve their fusional divergences, and this is quite a common slide, so I kept on this. So you can give this kind of exercise to improve their binocular vision functions, or you can have a composite of all
offers this
giving
dichoptic
anti-separation
therapy in the form
let us
of
go through this
gaze.
video.
The better eye receives weak, noisy signals as compared to the amblyopic eye. With progressive improvement in visual acuity, the games can be made more difficult with control on the size, speed, and crowding of the stimuli. There are different games with a scoring system for better patient engagement and compliance.
So what the composite tool for management of amblyopia, dichoptic base, helps you not only to adhere with the program by different activities, it takes care of the anti-crowding effect, it takes care of the contrast adjustment, it takes care of the speed recognition and all the component of binocular vision, improving the fusion and stereopsis. So coming to the point again, when you start any binocular approach, when you start improving the visual functions, not only look at only the acuity, you also look the concept of improvement the fusion and stereopsis, which will make it a successful treatment protocol. So take home message, let us see what we understood from this small talk of today's program. Let us see what you feel about the program, about amblyopia management. So what should be the treatment of choice in management of amblyopia? The gold standard is there as a occlusion therapy, but after knowing the fact, after knowing the concept, how the amblyopia works, neurophysiology, and after knowing the effects of dichoptic management protocol, what should be your treatment of choice? It is again individual acceptance, understanding, and but rationally we'll try to explain why one particular program is going to be better than the other. So as of now, I can see 49% people already voted. Yes, exactly 50%. Let me just give at least a minute time, couple of seconds more to get response. So 47% of you failed. The dichoptic therapy is or should be a treatment of choice, and followed by 36% failed combination of all. And there is a small percentile of still feel that occlusion therapy is treatment, and then very few failed the penalization. Now, before we summarize, let us understand this slide one by one. Now, again, going back to occlusion therapy is fruitful only when it is within your plasticity period of visual development of monocular neurons, so which is approximate till or up to 10 years of age. Now, problem lies with all those 6 parameters we talked about. You stop therapy, there will be recurrence, a very poor compliance. There are social stigmas which I have not mentioned, but a lot of stigmas from peers of the school's friends. A lot of comments comes to the child. Lot of issues in their monocular or binocular vision deficit. So occlusion therapy is not actually an option when the child is mature enough to follow any dichoptic protocol. So probably it needs around 4 to 5 years of age to start with dichoptic therapy. Till then, yes, you can give occlusion therapy, but not after that is a choice of treatment. As my perspective, yes, individual will have their different opinion. Penalization anyway not a good option. Coming to the dichoptic therapy, going forward, it's most likely going to be the treatment of choice or new paradigm or gold standard over a period of time. And then combination of all whom you failed, that 36% you failed, combination of all can be option is totally no. So absolutely there is no scope of combination of dichoptic, which is binocular therapy, and the analog model occlusion and penalization, which is monocular therapies. Please remember the pathophysiology and the mechanism are exactly not matching with these 2 components. So when you give dichoptic therapy, it works on binocular neurons. It do not advocate to suppress the dominant eye. Whereas in patching therapy, it advocates to suppress the dominant eye by reducing the inhibition for the non-dominant eye. Opposite side, in binocular therapies, you are decreasing the contrast of the dominant eye, but promoting a binocular approach. So combination is straightforward no, yes, the dichoptic therapy is going to be a choice, and then occlusion therapy if you are confident enough about the adherence to the protocol and all those things, you can still go ahead with the patching therapy or occlusion therapy. So that sums up my presentation. Let us open up for the discussion. Thank you for your valuable time and the concentration, activeness throughout the presentation. Look forward for the further questions. If you have, let me know, and we'll definitely respond to it. A good day.
Thank you very much,
My
Oli.
pleasure. Stay safe, stay home till the time everything becomes all right.